Hi everyone, thanks for joining us. We'll be getting started in just a minute at the top of the hour here. Hi everyone, good afternoon and thanks for joining us for today's virtual session, Integrating Clinical Pharmacy with Diabetes Management. This is part of our Integrative Approaches to Addressing Diabetes series, delivered by us, the Primary Care Development Corporation, and a component of the SAMHSA Center of Excellence for Integrated Health Solutions, which is housed at the National Council for Behavioral Health. Next slide. If this is your first time joining us, PCDC, a Primary Care Development Corporation, is a national nonprofit organization based here in New York City with a mission to enhance primary care and also related entities through advocacy, through capital investment, and through training and consultation in a host of topics, including integrating primary care and behavioral health. Next slide. We have a brief disclaimer for you. The contents and views and opinions that we're discussing today are that of our presenters and not expressly those of the federal government, including SAMHSA, the Center for Mental Health Services, Health and Human Services Administration, or any others. Next slide. And I am your moderator, Andrew Phillips, Senior Director of Clinical and Population Health here at PCDC. Just so you know, today's slides and the recording will all be available online for you at pcdc.org and also at the nationalcouncil.org/integrated-health-COE. We will also have a question and answer period at the end today, and you can use your chat box there on your screen if you're logged in through Zoom to enter questions or comments throughout, and we'll get to those later in the presentation. Next slide. So just a really quick poll, we know that obviously circumstances are, far from usual. Just out of curiosity, what's life like where you're viewing? Are you in a clinic somewhere or a hospital? Are you working from home? And if you're working from home, are you working under any unusual, particularly unusual circumstances with other things going on around you, perhaps taking care of children or family members or something else? And if it's an other, use the chat box. Let us know, where are you dialing in from? So we'll give just a couple more seconds for our poll. And we can go ahead and review the results here. So it looks like, not surprisingly, and good to hear, just under half, 43% of you are dialing in from home and things are otherwise normal. But also almost 30% of folks are calling in from the clinic, and thank you for being on our front lines there. And of course, we also have folks who are working from home with others and in non-clinical settings. Go to the next slide. And so, as I mentioned, this is part of our series. This is actually number 4 in our series. And so, again, the recordings for the other sessions on clinical topics are available on our website. And also coming up next month, I want you to know that we have a session on quality improvement, followed by one on operations and clinical pathways. So kind of what are the implementation steps for integrating primary care, behavioral health with a focus on diabetes. And of course, our session on people with lived experience, including peers and others. Next slide. And so this is really, this is almost like a 201 level approach to integrated care. So if you've been joining us all along, earlier in the year through the SAMHSA Center of Excellence, we had a session on primary care behavioral health integration and different models. And this is kind of the next step. Talking today about the importance of clinical pharmacy and really what it looks like when we integrate this service along with behavioral health and primary care and really integrate clinical pharmacists as part of the team. go to our next slide here, is Dr. Donna Lisi. She's an experienced clinical pharmacist, and she works now with Hackensack Meridian Health. But she has extremely diverse training and expertise, which we're really excited about. She has 4 board certifications, including pharmacotherapy specialty, psychiatry, ambulatory care, and also as a geriatric pharmacist with some postdoctoral training in geriatrics. She also has a background as medical training faculty, and she's an advocate in public health. She writes, and she's also a consultant. So Dr. Lisi, we're excited to have you, and I will turn over to you for our presentation today.
Thank you so much, Dr. Phillips, for that wonderful introduction. And I'm delighted to be here with you today. I'm so appreciative of Andrew reaching out to me several months ago and asking me to do this webinar. And I want to thank you for joining us for this webinar today, taking the time out of your busy day. Next slide, please. So today, we're going to be covering a lot, and I will be moving fast. So the first part of this lecture, there'll be 2 parts. We'll be looking at and answering some of these questions. The first one is looking at why should you include a clinical pharmacist on your team, looking at the value that a clinical pharmacist offers. We will also look into the outcome data that's available on pharmacists being involved in a diabetes management program. And lastly, we will look at the role of the pharmacist in managing complications and comorbidities that occur with diabetes. Next slide, please. In part 2 of this presentation, we will look at principles of diabetes pharmacotherapy, or what I like to call clinical pearls, and how these can be incorporated into practice. We will briefly discuss shifting patterns in diabetes pharmacotherapy, and then I want to take a deep dive into a population health-based approach. Next slide, please. So let's get started. This is part 1. Okay, next. Here we see the training that goes into being a pharmacist. And keep in mind that all of this is focused on drug therapy. Pharmacists graduate from a 6-year Doctor of Pharmacy program, or in my case, and some of us older folks are still around, I went through a 5-year Bachelor of Pharmacy program and then did a 2-year thesis Doctor of Pharmacy degree for a total of 7 years. In addition, pharmacists are involved with postgraduate training and residency programs. They can do a general residency program, or they can specialize in an area. They can do postgraduate fellowship programs. I did one in geriatric pharmacy. They can have board certifications. In addition, they can have other types of certifications, like being a certified diabetes educator, or medication therapy management with a specialty in diabetes, or even board certified in advanced diabetes management. In addition, every pharmacist has mandatory state requirements for continuing education that they have to fulfill. Next slide, please. This is a chart that highlights some of the roles of the pharmacist. But what's most interesting about this chart is where it was published. This was actually published in the Journal of American College of Cardiology, and it outlines 3 roles for pharmacists: 1, patient-specific services, facility-specific services, and then global services. And of these, I'd like to point your attention to the last one on that list, which is public health initiatives. And it's that I will focus most of the presentation on, taking a population health approach. Next slide, please. In 2002, the American Society of Health System Pharmacists delineated the role of the pharmacist in diabetes management. It stated that a pharmacist can be involved in patient identification and assessment, and patient education and referral, as well as in monitoring diabetes care. Next slide, please. Subsequently, ASHP issued a statement on the pharmacist's role in primary care. Here it teased out some more specific roles, where pharmacists are involved in patient assessment of medication-related factors. They're involved in ordering labs and interpreting data, as well as monitoring and modifying drug therapy and counseling patients. They also document a patient's care in the medical record and identify barriers to adherence, which is very important. They can participate in multidisciplinary review, as well as be involved in communication on multiple levels with payers, with prescribers, and most importantly, with other team members. Next slide, please. Well, great. So a pharmacist has all this training. They're highly educated professionals, but what value is of all this? Well, this is the first study, the ASHP project. It's a longitudinal study that was first launched in 1997 that took a closer look at the value of pharmacists in diabetes management. This was a study that was conducted in Asheville, North Carolina, and the results here look at clinical, economic, and humanistic outcomes of pharmaceutical care delivered by community pharmacists to patients with diabetes. It involved 12 community pharmacies and employees who were the dependents from 2 self-insured employers. Initially, they started out with 85 patients who were followed over 7 to 9 months. Over the years, and the study is still ongoing, they've had over 500 patients. And they did report on their initial first 5-year follow-up. Next slide, please. So this is data from the first 194 patients that went through the trial. And what we see here is this is the benefit of interacting with the pharmacist. There was a mean improvement, the mean hemoglobin A1C improved by over almost 60 to over 80%. There was an improvement in the percentage of patients who were at goal, which was an A1C of less than 7%. Lipid profile improved. In addition, cost benefits were visualized here too. So there was a total mean direct medical cost decreased, as well as the number of sick days decreased, which led to increased productivity, amounting to over $18,000 a year annually. Next slide, please. This is a timeline of studies examining the pharmacist's role in primary care. Next. Okay. And these are some more studies, also looking at this role. Next. So the bottom line of all of these is that pharmacist involvement in the management of diabetes improves patient care. Next slide, please. The federal government recognized the major contributions that pharmacists can make in managing diabetes. This is an action guide for pharmacists to encourage their participation in the National Diabetes Prevention Program. This program is designed to catch patients while they're still in the pre-diabetes phase. That means that they have a hemoglobin A1C of between 5.7 and 6.4. Pharmacists can be involved on multiple levels. They can be involved from mainly just raising awareness. They can go to the next level, which is screening and testing, or they can actually be coaches and providers of lifestyle changes that are part of the National Diabetes Prevention Program. Next slide, please. This goes back to that article that we just mentioned. And this is from that article that was published in the Journal of the American College of Cardiology. Here, they talk about the role of the pharmacist on the team and how pharmacists can help with optimizing drug use, avoiding adverse events, and helping, especially during transitions of care, where they can assist with medication reconciliation and patient education. It's interesting to note, too, on this slide that the conclusion of this paper on the role of the clinical pharmacist in the care of patients with cardiovascular disease was that they advocated for pharmacists to be able to practice to the highest level of their skills because they provide high quality, efficient care. Next slide, please. So we've talked about how the pharmacist can be involved in managing diabetes. Well, what about the pharmacist's role in managing complications of diabetes? Here, pharmacists can work with the team to manage cardiovascular risk, such as coronary artery disease or hypertension. They can suggest the appropriate use of ACE and ARBs in this population. They can help to really adjust doses, especially in patients with diabetic nephropathy. Or they can assist with drug selection for neuropathic pain, trying to avoid the use of opioids whenever possible. They can encourage good foot hygiene and send reminders to patients about visiting the podiatrist, as well as their ophthalmologist, in order to detect retinopathy early. Next slide, please. We also know that patients with diabetes have many comorbidities. This is a list of several of them. And as you can see, all of these are managed by drug therapy. So a pharmacist is a fully integrated part of the team, can assist in trying to manage these comorbidities as well as the complications associated with diabetes. Next slide, please. So now I'd like to turn our attention to part 2. And what I'd like to call this section is Clinical Pearls from a Clinical Pharmacist. I like the saying I like the saying on that previous slide, okay, that says, now is no time to think of what we do not have. Think of what you can do with what there is. And this section is basically clinical pearls and tips that can be implemented in a clinical practice now, even if you do not have a pharmacist, which would be the ideal situation. But if you don't have that, you can do you can implement these strategies right now, even under those circumstances. Next slide, please. So this is a great place to start. This is the American Diabetes Association Standards of Medical Care in Diabetes. Every year this is published in January. So this is the 2020 edition. Next slide, please. What this standard does is it identifies goals of care. I like to point your attention to the pink box, which is the issues that contain specific factors that impact choice of therapy. Next slide, please. This is a table that came directly out of the guidelines, the ADA guidelines. And in this table, this looks at weighing different factors in selecting medications. And this is something that pharmacists can be very involved with in helping too. Looking at efficacy and risk for hypoglycemia, the effects of weight on the effects of medications on weight and cardiovascular effects, as well as cost and routes of administration, and also to renal effects. These are all important factors to keep in mind when drug therapy is chosen. Next slide, please. This algorithm divides treatment of diabetes based on the presence of a number of factors, such as atherosclerotic heart disease, heart failure, the risk of hypoglycemia, obesity, and cost. And pharmacists can be a valuable tool if they're present, but this algorithm can also be used. And as you can see in this algorithm, there's been a shift in recent months and recent years away from insulin. Here we're seeing more use of the SGLT2 inhibitors and the GLP-1 receptor antagonists. Insulin, especially even basal insulin, is further down on the list. Other areas to look at here is hypoglycemia, and if weight is an issue, what drugs to pick. And the last column is cost. And what I want to call to your attention is if you look at the other columns, and you see the agents that are selected for the other columns, if someone has heart disease or heart failure, hypoglycemia risk, the sulfonylureas, the older agents, are not high up on that list. But when cost becomes a factor, some of these older agents that have more side effects become the preferable agents. And that is a little disconcerting, but that's the reality of when we're dealing with financial constraints, unfortunately. Next slide, please. This is an algorithm on how to escalate therapy for insulin if insulin is used, and pharmacists can be helpful in implementing this workflow into the clinical practice. Next slide, please. So now I want to take a deeper dive and look at the treatment of the patient with diabetes from a whole perspective. And for that, I want to turn our attention to population health. Next slide, please. These are the pillars of population health and the social determinants of health, looking at economic stability, neighborhood and physical environment, education, food, community and social context, and the healthcare system. Next slide. So I've taken those principles of population health and have applied them here to the management of diabetes from a pharmacist's perspective. And what I'd like to focus on, and I won't be able to cover all these in great depth, is looking at economic stability, looking at insurance coverage and costs and how that affects drug therapy. We just briefly touched on that. But what can we do? Does the sulfonylurea have to be our first choice for our patients? Can we do better? Looking at issues like that. Neighborhood and physical environment and how that impacts on patients' compliance and being able to follow treatment regimens. Whether or not pharmacy delivery services available. Is the community senior friendly? Is it safe to be able to promote physical exercise or even to be able to get to medical appointments or to the pharmacy? Looking at homeless populations in the community, as well as focusing on racial differences to drug response. Under education, I will briefly touch on health literacy and English as a second language, as well as we talked about pre-diabetes prevention and educating as well about diabetes, as well as on the complications that we just mentioned. Patients need to be aware of what they need to do to prevent these as well. With food, we can look at the interdisciplinary diet and nutrition education and look at timing of medications around meals, as well as preventing food-drug interactions and the use of natural products by many patients. And then lastly, talk about medication management around periods of fasting. The fifth pillar of the social determinants of health is looking at community and social context. Here, the pharmacist being the most accessible person in the healthcare team plays a major role. Pharmacists are involved in community engagement, as we saw in the diabetes prevention program. They're involved in community education, outreach, and identifying outcomes, as well as smoking cessation and psychosocial support. And the last column is on healthcare systems. Here we can look at medication reconciliation, continuity of care, pharmacist-led diabetes clinics, looking at what pharmacists can do to ensure medication safety by conducting medication reviews, what the role is of the consultant pharmacist in the long-term care setting, caring for older adults, and then lastly, user-friendly devices. Next slide, please. So the first topic that I wanted to touch on is economic stability and look at the management of diabetes from the pharmacist's perspective. Next slide. Excuse me. So this is a survey that was conducted of patients with type 1 and type 2 diabetes who were prescribed insulin. And the primary outcome was looking at cost-related underuse over the past 12 months. This involved 191 patients. And what they found that 1 in 4 patients at an urban diabetes center, and this was conducted in Yale in Connecticut, reported cost-related insulin underuse, and this was associated with poor glycemic control. What was very disturbing was that more than 1/3 did not discuss this with their healthcare professional, and that around 2/3 could not even afford the diabetes supplies. The bottom line is that in this financially disadvantaged group, the odds ratio for poor glycemic control was almost 3 times. It was almost 3, so almost 3 times the risk of having a poor outcome. Next slide, please. This is a look at how insulin prices have increased over the years. This is showing the parallels between U100 insulin and U500 insulin, where we see that there's been a drastic rise in the price of U500 insulin, the more concentrated form of insulin over the years. And this has significantly impacted patients' ability to afford their medications. Next slide, please. The American Diabetes Association was very concerned about this trend in the rising cost of insulin. So in 2018, they commissioned the Insulin Affordability Survey. Next slide, please. And this is some of the findings of the survey. What they found is between 1/4 to 1/3 of insulin users had to choose between buying medications or food or keeping doctor's appointments, also having to choose between transportation and housing, and even more had to choose between insulin and going on vacations or having any type of entertainment. And this is in the richest country in the world, which I think is pretty sad. Next slide, please. So what can we do to help our patients? In the next few slides, I will be highlighting some programs that can help. This is a website and an app called goodrx.com. In here, you would plug in your zip code and plug in the drug that you're looking at, and it will give you the lowest cost of the drug in your area. Next slide, please. This is on the American Diabetes website, insulinhelp.org. This actually is a list of major insulin manufacturers, and it tells you how to be able to get insulin at reduced cost. Next slide, please. This is an organization, needymeds.org. This is a non-profit organization that can provide information as well as on drugs and medications and glucose meters and supplies as well. So there's the numbers there listed for you, and that's a great resource. Next slide, please. RX Assist is a comprehensive directory of patient assistance programs. So these would be the programs that pharmaceutical manufacturers might offer for patients to obtain drugs at a lower reduced cost if they don't have insurance. Next slide, please. The National Council on Aging has a Center for Benefits Access, and this is a program for seniors as well as younger adults with disabilities. They will actually help enroll these folks, seniors and younger adults with disabilities, into different types of programs, whether it's Medicare, whether it's a SNAP program. This can also help offset some of those other costs of living that would conflict with having to pay for medications. Next slide, please. These are two programs. RX Hope is the largest independent web-based patient assistance resource, so they help people navigate the patient assistance programs, and then RX Reach helps patients find medications at the lowest cost. It's a network of community pharmacies that participated in that program. Next slide, please. This is one that is especially of interest to me. This is Dispensary of Hope. This is a program that my hospital, Hackensack Meridian Health, is affiliated with. Dispensary of Hope collects and distributes millions of dollars of pharmaceuticals annually to pharmacy and safety net clinics to dispense to low-income chronically ill patients. So this is one of the ways that my health system is trying to help this meet the gaps in the social determinant of health, so that even those who cannot afford medications can have access to them. Next slide, please. The medication assistance tool is a search engine that identifies facilities, or actually caregivers. It actually identifies resources available through various drug companies that have access to low cost medications. And then lastly, Inside RX is a free discount card service. They not only provide discounted access to medications for humans, but they also have, you can also get your pet medications through Inside RX discount card. Next slide, please. So now I'd like to focus on the next social determinant of health, which is neighborhood and physical environment, and how this can, the pharmacist can help manage patients with diabetes who have issues that deal with this area. Next slide, please. One of the biggest problems with adherence is access to care. Many pharmacies, especially major pharmacy chains and many local independents, have delivery service. Next slide, please. This is a website called getmyrx.com, which networks with community pharmacies, and they, if there isn't one in your area, they have a network of 300 pharmacies, actually in 300 zip codes across the country, and the pharmacies under those zip codes, and they would be able to deliver medications right to someone's door. Sometimes they can do them within the same day. Next slide, please. Since we've all been under shelter in place due to the COVID-19 pandemic, there's been a resurgence of telehealth. Well, one of the other areas to focus on is telepharmacy. Telepharmacy, I think prior to the pandemic, had been an up-and-coming field, and I think now it's really taken off. This is an early study that looked at telepharmacy in the form of e-visits using MyChart. In this study, 36 patients were followed over 2 years. Patients were encouraged to attend an initial pharmacotherapy clinic where their literacy skills were assessed. And in this case, 66% of the diabetes visits were only through e-visits, using communication through MyChart. And even with that limited degree of high tech, they found that there was a 3.4 percentage point difference after 5.7 months, or after about 6 months, in the hemoglobin A1C in patients who ascribed to this program. In addition, there were improvements in statin use and aspirin use, as well as improved blood pressure control. The study looked at diabetic patients as well as patients who were on warfarin, and they also found a decrease in the percentage of patients who had extreme INR levels. Those were also significantly decreased. So overall, this program was considered a success. Next slide, please. This is another example of telehealth. This was actually a more elaborate program that was run out of 3 primary healthcare clinics in Oregon, in which they had a whole telephonic system in place. And what they basically found that in 16 weeks, in just 4 short months, they also saw a decrease in hemoglobin A1C when this telephonic program was run by a pharmacist. Next slide, please. Another component with social determinant of health in neighborhoods is looking at the 4 M's for an age-friendly society. There are 2 different age-friendly themes. One is an age-friendly society or community, and the other is an age-friendly health system. These are some of the components of an age-friendly health system. Here, it's the 4 M's: what matters, medication, mentation, and mobility. And we see that under physical environment, social determinant of health, both medication and mobility would definitely play a major part, being able to have access and getting to doctors and pharmacies, as well as being able to physically exercise. Next slide, please. I mentioned that we would talk about homelessness, and this is an important area. In fact, this is actually identified and discussed in those ADA guidelines that were published in January. According to the American Diabetes Association, about 8% of patients who have diabetes are homeless. This leads to issues with food insecurity, lack of insurance, being able to not have a nutritious diet. Also importantly, how to be able to secure prescriptions and store their diabetes medication and supplies. What do they do when it's 95 to 100 degrees outside, and they have insulin? So this is an area where pharmacists can work with social workers to help address those concerns. In addition, programs like the Dispensary of Hope that I had mentioned, this would be a great way for patients who are homeless or don't have any insurance at all to be able to get medications. Also, being involved with free clinics and veteran centers are another key area. I had been involved with that when I had worked at the VA for 7 years. Next slide, please. So one of the final points I want to talk about in this area is looking at racial differences in diabetes prevalence. The healthcare team needs really to assess the role of race when it comes to drug selection. Here we see that minorities are disproportionately affected by diabetes. Next slide, please. I put this slide in here. This is a major area of interest of mine, pharmacogenomics. And pharmacogenomics is basically pairing the pharmacology of drugs with the genetics of a person to try to optimize drug therapy based on a patient's genetic background and genetic makeup. And I could say that in many areas, this topic is much further along. So in the area of oncology and other areas, we know more than what we do for diabetes. This is a very up-and-coming area. It's a very young science, but there's some preliminary evidence that these 4 medication classes may have a difference in how they work in different people depending on their genetic makeup. And like I said, stay tuned because there's more to come in this area. Next slide, please. The next pillar of social determinants of health is education. And this is a diagram from the CDC, which talks about the consequences of low literacy. There are more emergency room visits, there are increased hospital stays and length of stays, there's non-adherence to treatment programs, as well as there's higher mortality rates, higher morbidity mortality rates. Next slide, please. Here we see the diabetes self-management program, the components of that, nutrition, education, and emotional health. And these are all areas that a pharmacist can help with, or they can actually be addressed in managing the care of patients who are in the clinic area right now. Next slide, please. So when we look at health literacy, this is there are 2 references here that I point your attention to. The bottom one is where this chart was taken out of, and I definitely like this chart. This is a table that's set up looking at the medication, having a picture of the medication. You could actually you could actually get one from the internet, the actual pill if possible, and then it shows you graphically how to take medication based on time of day, based on meals. This would be a useful tool for somebody with low literacy. Pharmacists can help the healthcare team assess the patient's ability to do all these various things, such as calculating dosing intervals and drawing up the correct amount of insulin, how to interpret medication instructions and labels, develop ciphering charts, looking at insulin to carbohydrate ratios, and also, too, most importantly, assessing risk versus benefit when they have to make important decisions about their health care. That paper from Diabetes Educator showed that as education went up, especially individualized education, hemoglobin A1C went down. So education is a powerful tool to help manage patients. Next slide, please. We talked a little bit before about the pre-diabetes program and the National Diabetes Prevention Program, where pharmacists can be involved with. In addition, another role that pharmacists can play, still while the patient's in a pre-diabetic state, is looking at trying to encourage vaccinations. And this could be during pre-diabetes as well as if the person goes on to develop diabetes. These are very, very important areas for them to help protect their health. Next slide, please. We've talked about the pharmacist's role in managing comorbidities and complications. Well, another component of that is educating patients about how to manage them as well. So looking at smoking, if someone's a smoker, trying to educate them on smoking cessation, helping them to identify diets and exercise plans, and choosing weight neutral or weight loss anti-diabetic agents, physical activity, trying to promote exercise, explaining the importance of checking their hemoglobin A1C and their blood glucoses, as well as monitoring their blood pressure and cholesterol levels and following treatment guidelines that have been implemented for them. Next slide, please. So food is the next pillar of the social determinants of health. And here, once again, we see ramifications for the management of diabetes by the clinical pharmacist. Next slide, please. There's a movement in this country to treat food as medicine. This is exemplified by the saying that you are what you eat. Pharmacists can assist the team in the approach by encouraging patients to engage in healthy lifestyles, and this will include eating a healthy diet. resources are available, such as counting carbs or plate method from the CDC. In addition, I'd like to call your attention to that boxed article. This is on the importance of pharmacists' expanding role on the diabetes team, reinforcing nutritional guidelines for improved glycemic control. What I most especially like to call your attention to is the date on that article, 1997, in the last century. So this is an area that pharmacists have been involved with. It may not have been something that's been in the forefront, but it's something that pharmacists have been involved with for quite a long time. Next slide, please. This is an area that pharmacists can play a key role, as well as helping to identify the timing of medications around meals, looking at what medications, what anti-diabetic medications need to be administered before meals. In the case of some of these medications, they need to be administered at the time of the meal, or they should be administered with meals to prevent stomach upset. Another important role for the pharmacist that they can help or shed some advice on is looking at how to adjust medications during fasting states. Right now, we're in the month of Ramadan, and for our Muslim patients, it's very important so that they don't experience problems with hypoglycemia. There is an article that's published in the British Medical Journal, Open Diabetes Research and Care. This was guidelines by the International Group for Diabetes in Ramadan that would help give guidance on how to adjust medications for our Muslim brothers, sisters. Okay, next slide, please. This is a table that's used to help optimize insulin therapy. It looks at such things as onset and peak and duration of effect of insulin. Next slide. So I teased out some of the information from that slide and looked at how that impacts on meal administration. So the last column on this table looks at when to take insulin with regards to meals, depending on the type of insulin we're talking about, rapid acting, fast acting, or short acting insulin. Next slide, please. Another area that pharmacists are very involved with is identifying food-drug interactions and trying to prevent them. This is an area where pharmacists can work with dietitians to help optimize someone's diet in addition to the medication regimen. We know that grapefruit and grapefruit juice interacts with many medications, and among the diabetes medications, it can interact with glucagonide and saxagliptin. Also, too, patients who are on metformin, which is our mainstay first-line drug, patients who have been on that for a prolonged period of time can develop a vitamin B12 deficiency. So a good recommendation would be for any patient who's on the drugs for over a year, you might want to check the B12 levels. And then also, too, if patients are on some of those older drugs, the sulfonylureas, if they take those drugs with alcohol, they can develop what they call disulfiram reaction, which is very uncomfortable, involves facial flushing and really feeling miserable. So we want patients to be able to avoid that consequence of medication therapy. Next slide, please. Another area that's important too, and I put this on the food just because these are usually orally ingested, is that patients with diabetes are almost 2 times more likely to use alternative or traditional medicines compared to patients without diabetes. And there's a lot of hype out there and a lot of different ads that you may see for these products. Unfortunately, they're not subject to the same safety and efficacy regulations as a prescription drug. Basically, they have to just more or less state that they're used to help maintain a bodily function. They cannot be stated in their product labeling that they're used to treat a condition or that they're used to prevent a condition, but they can say things like they can enhance blood glucose control. So these are 2 drugs here that are very common, widely used in patients with diabetes, chromium and zinc. And while there's a good amount of evidence supporting the use of chromium, it's important to know that chromium can interact with thyroid medications, particularly levothyroxine. And so patients need to space the dosing of that. The same thing with zinc. Zinc can interact with fluoroquinolones and make them less effective. Next slide, please. So I want to turn our attention to the next social determinant of health, our 5th one. And this is looking at mental health, which is a large component of that. Next slide. I would be remiss, since we are in May, to not discuss that May is Mental Health Month. This is a very important month, especially now, given the psychological consequences of COVID pandemic. A lot of patients are stressed, both by tragedies that they may have faced personally in their lives, as well as the physical and emotional distancing that has been placed, that's necessary to combat this pandemic. This is an area that I'm especially interested in. As Andrew had mentioned, I'm a board-certified psychiatric pharmacist, so I can fully appreciate the importance of this topic. The website that's listed there has a list of resources, and the theme this year is Tools to Thrive, and you can find those resources free of charge at that website. Next slide, please. I know that PCDC has focused on mental health issues in the past, so I will not take too much time on this area, but just looking at some of the statistics, depression affects about 1 in 4 adults with depression, and that depression affects 1 in 4 adults with diabetes, and that when we look at diabetes distress, anywhere from 20 to almost 50% of patients with diabetes suffer from that. I would think that given the fact that diabetes is one of the risk factors for poor outcome if you're infected with COVID-19, that fact is probably adding some stress to our patients as well. And lastly, patients with diabetes suffer from elevated rates of anxiety symptoms too. Next slide, please. This is another area to look at, is the effects of psychotropic medications on diabetes and glucose regulation. This was an article, this is a journal that I published, an article in Diabetes in Psychiatric Patient. I published this a while back. And in this article, it looked at medication profile and the effects of weight and lipids and how these can have a negative impact on adherence. A more recent article I have listed there in your slides is drug-induced hyperglycemia and diabetes. And here this is taking a more pharmacogenomics perspective on this condition. Next slide, please. This is a table also from that article that I authored, looking at the amount of weight gain associated with some of the different psychotropic medications, whether they antipsychotics or antidepressants, mood stabilizers, or stimulants. It also this also ties directly to the metabolic complications. So the weight gain would be directly tied to the metabolic syndromes that we see in patients who have diabetes and are on psychotropic medications. I call your attention to the bottom of that slide. This was guidelines by the British Association of Psychopharmacology on weight gain, metabolic disturbances, and cardiovascular risk associated with psychosis and antipsychotic drug treatment, and that's from 2016. Next slide, please. Okay, this is a table also from the article I authored on preventing and treating antipsychotic-associated adverse events on glucose, insulin, homeostasis, and lipid metabolism. It gives you different options depending on what the problem is that exists. Next slide, please. So these are studies in which the pharmacist has taken a proactive approach in screening and monitoring patients with diabetes for mental health issues. So in the first set of articles, we see that the pharmacists assist in referrals for depression evaluation. Here we see that this is especially true in primary care setting, and then also we see that pharmacists are involved in assisting with the monitoring for the metabolic effects of the psychotropic medications. Next slide, please. So now I want to address our last component of the social determinants of health. This is our sixth and final one, and it's the healthcare system. And this is basically my home base. Here, pharmacists are involved in every aspect of diabetes care, from dispensing medications to collaborative practice agreements to recommending treatments, to be involved in consultant services, monitoring patients, and even conducting research, to name a few. Next slide, please. Medication reconciliation is defined as the process of comparing a patient's medication orders to all the medications that the patient has been taking. This reconciliation is done to avoid medication errors such as omission, duplication, dosing errors, or drug interactions. And it's a complicated process with many moving parts. And this is something that the pharmacist can be especially helpful for in trying to identify what the patient's medications lists have been as they move from different care settings during transitions of care.
Donna, I think we may have lost your audio. Let me know if you're able to hear us. We'll just give it a second. Just for folks on the webinar, we're just experiencing a momentary issue with Dr. Lisi's audio, but we'll have her back in a moment. Okay, well, while we wait for Dr. Lisi, Chaim, you can actually go to the next slide. Fortunately, we were able to talk through a few of these, and I'll just expand while we wait for her to rejoin us here. So another area that, in my discussions with Dr. Lisi that came up was, around effective transitions of care. So obviously when we're talking about patients who are coming from both behavioral health or primary care or in and out of the hospital in particular, we know that there's huge issues there. And especially when we're looking at health outcomes, but also metrics related to care. And when we're talking about diabetes, we know it's high in complexity, and we really need our patients to be engaged with not just with their providers, but with the full team, and there can be communications breakdowns here. So a few of the areas that Dr. Lisi had mentioned, we're really considering multiple roles to avoid communication breakdowns, thinking about, the coach, the kind of educator within the team, but also pharmacists as members of this interdisciplinary team. And using the pharmacists, particularly to help address any of those breakdowns if we see any kind of issues with accountability, again, kind of navigating these with use of the pharmacist as well as other members of the care team. And that point about education is really important too. We know that many patients, although they've been prescribed a medication, they may not have either gotten or necessarily understood a lot of the instructions that are coming with their medications. And so certainly, as behavioral health providers, we see this very frequently. And, this is really an area to kind of key in the pharmacist, or, if you're the pharmacist on the team. Proceed to the next slide there. We'll just do one more check to see if Dr. Lisi was able to join us here. Okay. So as she's coming back, next one here is the pharmacist-led diabetes specialty clinics. Again, she goes through a few different articles and resources here, particularly on the effects of pharmacists being involved in diabetes and actually improving the outcomes, not only of the experience of care, the efficiency of delivering care, but in actually improving the outcomes of care. We can head over to the next slide. And another one really that particularly healthcare systems pharmacists, from that systems level perspective that Dr. Lisi was mentioning, can really consider the needs of monitoring therapy, using these drug reviews, but capitalizing on that system, particularly if you have a shared electronic health record. I know she was really thinking through, how can you use drug reviews or the drug audit tools that are within the electronic health record that the whole team has access to address some of these things. Go on to the next slide, and I think Dr. Lisi will be joining us in just a moment here. So here we're talking really about the use of drug therapies within the long-term treatment clinics. So Dr. Lisi had mentioned one of the manuals that's available here on your screen, and you can see you have the link there. And I know a lot of folks have been asking about getting copies of the slides and also being able to examine some of the resources more closely. And those things will be available to you, so you can access this here. But one of the nice things about this drug review process, again, not only for identifying or resolving medication-related issues, but also collaborating between members of the team, and when we have residential patients that we're talking about, also considering their caregivers or other people who are kind of intermediaries or involved in the course of medication and care. And this is some of what Dr. Lisi is doing right now. And so I think she'll be with us in just a moment for that Q&A section, but we'll head over to our next slide. And so this is, I love this term, Dr. Lisi was talking about deprescribing, right? And so, I'm sure a lot of folks on the line who are clinicians have also had this experience where our patients come in with these just like grocery bags of medications, and it can be confusing. What is the first, helping them understand why they're on different medications, but also thinking about duplications in medications. And is that Dr. Lisi?
Yes. Hi. I'm terribly sorry. The call dropped and I wasn't able to get back in.
No problem. So we're right here. I kind of coasted us through from some of our earlier conversations, but we were just on deprescribing. So if you want to pick up here, I think.
Sure. Let me just, okay. So I'm just going to some of the, okay. So deprescribing, I apologize again to everyone. It actually said call failed. That never happened before. Okay, so deprescribing. This is an important area where we're trying to basically debulk a patient's medication regimen. And these are some guidelines that have been developed by the Choosing Wisely initiative. Among them is trying to not use sliding scale insulin, especially in patients who are on insulin, and you don't want to use this as a long-term strategy. Is to avoid the use of medications other than metformin if the hemoglobin A1C is less than 7.5%. And the last one is from the American Society of Nephrology. This is to avoid the use of NSAIDs in individuals with hypertension, heart failure, and chronic kidney disease. This is an important area that patients need to be educated about, especially since these drugs are available not only by prescription, but over the counter as well. Next slide, please. Okay, so actually this is my last slide. This is basically looking at tools that are available. This is a handout from the American Association of Diabetes Educators looking at strategies for insulin injection therapy for self-management. I've also put on this list a document from the consultant pharmacist that looks at age-friendly devices, not only for diabetes, but for other medical conditions as well. And there is another reference on the bottom that are specifically for insulin and injection aids from the American Diabetes Association. Okay, so I apologize again for what happened, and I'll be happy at this point to answer any questions that anyone has.
Sure. I think we have one more slide on summing it up, and I think that's kind of a great point to go through some of your tips here.
Okay, sure, great, thanks. So summing it up, so the clinical pharmacist is an essential part of the diabetes management team, and we saw all the things that pharmacists can be involved with. They can be involved with not only managing diabetes itself, but also managing the comorbidities and complications associated with diabetes, as well as the concomitant medications for these comorbidities, looking at it from a perspective of drug interactions, drug-food interactions, timings of medication. We briefly touched on pharmacogenomics and how this is an up-and-coming area to keep an eye out. We talked about cost and how this is definitely impacts on adherence and how this also has affected selection of medications as per the ADA guidelines. And then we focused on the social determinants of health and took a deeper dive into how those all play a role in successful management of the patient with diabetes. And then the last thing was looking at principles of rational diabetes pharmacotherapy and how no matter what the situation is, ideally, if you have a clinical pharmacist on board, you would be able to do this. But then these are also tools that you can implement in a practice now if that's not the case. So with that, I believe that's my last slide. I would like to open the floor up to any questions.
Great. Thanks, Dr. Lisi. So we've gotten actually a few throughout the webinar, and also folks are welcome to continue typing their questions into the chat box. But one of an interesting question was about the role of race, and I think that that was one of the earlier slides that you mentioned in talking about kind of race in relation to some of the drugs. The question is, are any of the genes that you mentioned related to race, and in particular, how does some of the information around race and medication apply to people who are multiracial or with multiple racial ethnicities?
That's a great question. In fact, that's one of the burning questions that we're looking for answers for. A lot of the studies that have looked at pharmacogenomics have really tried to identify different genes and the effects on different what they call cytochrome P450 enzyme systems in select populations. So they will look at these factors in a Caucasian or in an African-American population or Hispanic population. And so in order to be able to get a clear picture as to what a particular race does, usually these studies do not involve multiracial individuals. And so that is a very important point, because we don't know exactly where they fit into the spectrum. As far as diabetes medication, I listed 4 classes there. About the only one that we have some inkling is metformin. And with metformin, we see that perhaps, and this again is very preliminary, we really don't have, the science isn't there. Part of the reason the science isn't there with diabetes is that diabetes is polygenetic. So there are multiple factors, and it's thought too that medications, because there's so many different factors involved and so many different genes involved with diabetes, that medications, the role of medications and pharmacogenomics will probably be a very small part of that. The effect size will be very small. There is one condition where mature onset diabetes in which it does have a major role, and those patients are very sensitive to sulfonylureas. So if someone's diagnosed with mature onset diabetes of youth, they will be switched to a sulfonylurea with good success. But as far as race, that MODY is not a race-based diagnosis. The only thing that we have some inkling is that metformin might be especially effective in African Americans and Black patients. But other than that, we're very limited in the knowledge. A lot of that is done from observational studies, and that area we're not there yet.
That's helpful. Thank you. You know, we have a few more questions, and you know, I think it's always a little bit of a tricky process, especially when we're talking about good situations, really, where we have the luxury of those interdisciplinary, multidisciplinary teams. If I'm, you know, as a behavioral health provider, how do I navigate between figuring out what are the questions I ask to the primary care provider, and then what are the questions that I would sort of, or you know, discussions that I would have with the pharmacist? How do I navigate between those two roles in the team?
Well, I think, you know, I think that's an interesting question. I think when it comes to medications, those questions should definitely be asked and answered, you know, by both members of the team. But I think pharmacists are playing a greater role, not only in helping select drug therapy, but in monitoring drug therapy, as well as even ordering tests and ordering drug therapy under collaborative practices. I know one of those slides that was in my absence was Pharmacist-Led Diabetes Clinics. And some of those slides were resources there that showed the pharmacist's role that in those clinics, that they have had positive benefit in reducing hemoglobin A1Cs, as well as other complications in cardiovascular disease. So I think that from a team approach, you know, I trained, well, one of the places that I worked, I trained at Montefiore Medical Center, but as in my fellowship, and then I worked for 7 years at the VA. And I have to say, in terms of the team approach, that was one of the best experiences I had ever had, because it was the first time that I actually saw how the team can officially work with every member having a valuable role, and every member's contribution being weighed evenly. So it you know, it was a great experience. I'm not sure if that answers your question, but I think that I think medication-related issues with cost and compliance, all those factor in, and I think that it would be remiss to kind of pigeonhole things. And I think communication with all members of the team are very important, and discussing all these issues, because everybody might have a different intake or insight into how to address these concerns.
Great. And Chaim, you can advance us to the contact us slide, just so we have that in the background. But we have another minute here. And, you know, an interesting question. We have more questions. Unfortunately, we have time to answer, but a question around metrics. And so, you know, what are some key things to look at? And I think in particular, you know, are there any you know, values or metrics that you know, are a little kind of useful as a rule of thumb, for example, when we're talking about diabetes?
Well, from most of the studies I've looked at, one of the metrics has been reductions in hemoglobin A1C. You can also, and that's also to a HEDIS for those in outpatient ACOs. That's an important one as well. But I think too, looking long-term at comorbidities and looking at rehospitalizations for hyperglycemia, looking at the rates of hypoglycemia, especially in older adults, I think those are some metrics that would be very important, because those are clinical outcomes. The hemoglobin A1Cs are great, but they're not showing us, does a patient have hypoglycemia, is subject to passing out or having syncope and ended up, falling, breaking a hip, that, having issues with that. So I think there are many different metrics. The most common ones have been looking at reducing hemoglobin A1C level, and then also the effects on lipid, as well as on cost. Like I said, with the ASHP project, they saw a decrease in the amount of sick days that the patients who were involved in the program had as a result of their diabetes.
Great. And I think this that last point really speaks to, again, the value of the clinical pharmacists within the team. As a behavioral health provider, that's kind of working with the pharmacist is how I learned how to kind of talk to my patients about just some basics, right, without kind of exiting our scope. But we're actually out of our time today. So Dr. Lisi, I really want to thank you for taking the time. We've gotten many compliments in the chat here. Thank you for your expertise, and for sharing these resources with us. Is it okay if folks email you? I know there's a lot of questions about some of the tables and specific resources that you mentioned.
Sure, I'd be happy. My email address is there. If anyone has any questions now or in the future, please feel free to reach out to me. I'll be happy to help.
Okay, great. Well, thanks, Dr. Lisi. Thanks to SAMHSA, to the Center of Excellence for Integrated Health Solutions, and to all of our audience members for joining us today, submitting your questions and interacting with us. Join us next month for our parts 5 and 6 of our series here, again, on operations and clinical pathways and quality improvement. And we will see you then. Thanks, everyone.